healthy embryo is just the start, though,
Yeah.
isn't it? Wonderful news of a positive pregnancy test. What happens next? And how do you and your team help continue that pregnancy to term?
I think for most units, I mean, once they achieve a pregnancy, they don't really monitor the patients. They don't see exactly what happens, and the journey with the clinic would probably stop after the first scan, which is normally within a couple of weeks from a positive pregnancy test. We have done things differently for the simple reason, because I would say about 80% of our patients are people who have repeatedly failed before, and a high percentage of those patients, the primary problem is exactly what happened once the embryo implant and tried to develop and grow for the 9 months. And if you don't pay attention to this period and try and adjust the medication accordingly, either the patient will lose the pregnancy, or there might be complications, or they go into preterm labor and so on, because the end point for any patient or any clinic is to have a baby at the end of the journey, not just to start a pregnancy that doesn't continue. And we tend to monitor patients throughout most of the pregnancy. We used to sort of relax after 20 weeks, which is halfway through the journey, but we've realized that there is a small group of patients who seem to have like a flare-up around 20 weeks. And this is the worst possible scenario for anybody, having gone that far and then losing the baby 20 weeks, 22 weeks. So I think we carry on monitoring patients very carefully until maybe the last months of the pregnancy or so. And we sometimes give them extra medication, because we believe this extra medication will help with the progress of the embryos and make sure that there is no problems at any stage of the pregnancy. What I find very peculiar as well in our practice, I mean, most people who go through IVF, if you look at the statistics, they tell you there is a very high incidence of preterm labor and very high incidence of something called preeclampsia, when people just develop high blood pressure at the end of the pregnancy. We don't seem to see this in our practice and the patients that we treat. I think most of our patients actually do well. They carry on most of the pregnancy. The chances of them developing problems like preeclampsia is not as high as what the statistics would suggest.
Why do you think that is?
Because I believe it's because the extra medication that they take and the monitoring that they require. And we've been doing this now for 17, 18 years. So I would like to believe that we have seen a pattern here that is very useful, and we probably understand it a little bit more.
You say monitoring and medication. Talk to us about what they find out, the happy news that they're pregnant, then what happens?
Well, there are some basic medication that you're going to give to almost everybody, and which are essentially hormonal support. Essentially something like progesterone, which is very important in the second half of a cycle, and it helps with the early stages of implantation. And some people, sometimes the progesterone levels are not up to the right levels and they need support. So if you're not measuring those levels, you will have no idea whether they need support or whether they are on the right support, and so on and so forth. So that's the very basic level of monitoring. Some people will need extra medication in terms of, like, we give them sometimes anticoagulant drugs that make the blood flow maybe flow easily and help with the implantation and the development of the embryo, particularly in the first few weeks of implantation, because that's a very critical period. The first 12 weeks of the pregnancy, anything can go wrong, and you need to make sure that you stay on top of any potential problem. And sometimes when we check the levels, we can see variations, and we have to adjust the medication to try and keep the levels where it should be.
And you do that via blood tests?
We do this via blood tests, and also scans as early as we can, because you can't really see much in the early couple of weeks. So, I mean, until the patient is 6 weeks pregnant, which is roughly 2 weeks from a positive pregnancy test, this is the first sort of stage where you can probably see fetal heart and things like that. And then you can rely on the size and how the embryo is growing and the size of the sac and so on, because this will give you also indication about whether the embryo is healthy and whether it's progressing as it should be.
And you continue that until 40 weeks?
We don't, not till 40 weeks, but I mean, we monitor patients very, very carefully until 12 weeks. And then after that, some of this medication, we can wean them off them because they probably don't need them, because by that time the placenta is kind of fully developed and it takes over some of the stuff that we give to the patients. But the patients who require other things, particularly people who've got an implantation problem to begin with, which they may require things like heparin, They might require some drips that sometimes suppress some activity in the body. So we monitor those very vigorously until about 20, 22 weeks. If everything is okay after that, then you can probably relax and maybe just see them do simple things every 4 weeks or so on. And then they can just follow their obstetric care after that, whether it's local or private or whatever.